After gallbladder removal, the answer is not simple. Ozempic, semaglutide, and Mounjaro, tirzepatide, may still be possible, but not automatically safe. The gallbladder may be gone, but bile ducts, digestive signals, and the pancreas remain. The key is symptom pattern, timing, recovery, dose changes, and recent surgery history. Old attacks can disappear, while new warning signs still matter after successful surgery. The gallbladder is a storage pouch for bile. Bile is a digestive fluid made by the liver. The gallbladder squeezes bile into the intestine after meals, especially meals with fat. After gallbladder removal, bile usually flows more continuously instead of waiting in that pouch. Many people hear that gallbladder removal fixes the problem forever, and it often fixes gallbladder attacks. But it does not remove the whole bile system. The distinction between removing the organ and removing the risk is the point. The real question is whether digestion is stable, surgery is healed, bile ducts are quiet, and dosing fits. I'm Dr. Kim, a licensed physician. This is not medical advice. Consult your doctor. Most people adapt well after surgery, but not everyone adjusts the same way. Some people notice loose stools, indigestion, nausea, or right upper belly discomfort after fatty meals. Those symptoms may be mild, but they create confusion. The same area can also hurt during bile duct problems. These medicines slow how fast your stomach empties. That is one reason people feel full sooner and eat less. But the same effect can also cause nausea, bloating, constipation, vomiting, or abdominal discomfort. After surgery, that overlap can make symptoms harder to read. That overlap is why the question cannot stop at, "Is my gallbladder gone?" The safer question is more specific. Do new symptoms look like ordinary medication side effects or a bile duct warning sign? That distinction matters most when pain, vomiting, fever, or yellow eyes appear after surgery. Drug labels warn about acute gallbladder disease with these drugs. Acute means sudden or active. That warning includes gallstones, called cholelithiasis, and gallbladder inflammation, called cholecystitis. After gallbladder removal, the gallbladder part may no longer fit perfectly. But the warning still matters because the risk can shift location. A bile duct is a small tube that carries bile. A stone can remain there after surgery, and a new blockage can also appear. The common bile duct is one place doctors may check closely. Removing the gallbladder lowers one risk, but it does not make the bile duct irrelevant. Rapid weight loss adds another layer. Losing weight quickly can change what bile is made of and how it moves. In someone without a gallbladder, that concern is mainly about bile ducts, not a missing pouch. The medicine may be part of the story, but weight loss itself may also contribute. This can happen even after the original gallbladder attack has been fixed. If a bile duct stone blocks drainage, pain can become steady and severe. Yellow eyes, dark urine, pale stool, fever, or chills can also appear. Those symptoms are not routine medication side effects. They deserve prompt medical evaluation. At that point, the decision is no longer about whether a gallbladder exists. It is about where risk could show up now. A stable person is different from someone losing rapidly with new pain after meals. That second person needs evaluation, not reassurance. Pancreatitis is another reason not to oversimplify. Pancreatitis means inflammation of the pancreas, an organ that helps digestion and blood sugar control. Severe upper belly pain that travels to the back needs urgent attention, especially when vomiting continues. Do not try to diagnose that pain by location alone. Bile duct problems, pancreatitis, ulcers, reflux, and medication nausea can overlap. The safer rule is practical. Severe, persistent, worsening, or unusual pain should not be managed by taking the next dose. Basic testing can help separate routine nausea from a bile problem. Liver blood tests can show whether bile flow looks blocked. Ultrasound or other imaging can look for enlarged bile tubes or stones. A bile duct problem can also change liver tests before skin color changes. The test choice depends on symptoms, exam findings, and local practice. Testing can reduce guessing and help decide whether the next dose should wait. Even with reassuring tests, the symptom pattern still drives the next decision. Mild nausea that improves and allows fluids is different from pain with fever. Constipation is different from yellow eyes. Loose stool after fatty food is different from dark urine and pale stool. Some people need extra caution before starting or increasing the dose. Recent surgery is one reason to talk with a clinician first. So are stones left in the bile duct, unexplained right upper belly pain, repeated vomiting, pancreatitis history, severe dehydration, or persistent diarrhea. If symptoms are not urgent or evaluation is reassuring, recent surgery still changes the risk discussion. If surgery was last week, the body is still healing. If surgery was years ago and digestion is stable, the situation is different. The calendar alone is not enough, but recent surgery deserves a lower threshold for review. After full recovery, some people may be able to use the medicine. The stronger case is no ongoing bile symptoms, no unexplained pain, stable eating, and clear instructions from the treating clinician. If eating is still unpredictable, dose timing may need to wait. The decision may differ for diabetes treatment and weight loss only treatment. For weight loss alone, waiting may be easier than for blood sugar control. Before restarting after gallbladder surgery, use one practical checklist. First, confirm that the surgeon has cleared normal activity and diet. Second, confirm there are no continuing bile duct concerns. Third, know which symptoms mean stop and call instead of taking the next dose. Then make the dosing decision with the right information. Tell your clinician when surgery happened and why it happened. Say whether stones were found in the bile duct. Bring the surgery discharge summary if you have it. A prior endoscopic stone removal also belongs in that history. Dose increases still need caution after that safety check. Many problems appear during dose increases, not only with the first injection. If symptoms become difficult after an increase, pushing through is not always the best answer. A slower plan may be safer. Bring a dose and symptom timeline. Record when the medicine started. Note whether symptoms began after a dose increase, a fatty meal, rapid weight loss, or the surgery itself. That timeline often separates a drug side effect from a new medical problem. Do not use the next injection as a test. If a symptom feels unusual, pause and contact the prescribing clinician. A short delay is usually safer than ignoring a bile duct or pancreas warning. Restart only after the plan is clear. While that timeline is being sorted out, food choices can make the first weeks easier. Smaller meals, slower eating, enough fluids, and avoiding very fatty meals may help. They make it easier to notice symptoms that truly stand out. The safest answer is not fear. It is sorting people into the right group. No gallbladder plus no symptoms is very different from no gallbladder plus ongoing pain, fever, yellow eyes, vomiting, dehydration, or abnormal tests. After gallbladder removal, Ozempic or Mounjaro may still be possible, but the missing organ is not the whole story. The bile duct, pancreas, stomach emptying effects, symptom pattern, surgery timing, and dose changes matter. No gallbladder does not mean no warning signs. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.